I'd like to turn back to Dr. Joseph, who has been so grateful. I mean, we're so grateful that you spend the time with us every 2 weeks to give us an update. So Dr. Joseph, what do you have for us this week?
Well, thank you, Mr. Mayor. Before I share my screen with some slides, I think it's just so important to address the heroes of today. And throughout this epidemic, they have changed. I must reinforce, or at least agree with Supervisor Anderson, we have to thank the firefighters who are out there right now, this minute, risking their lives. And then the tough part right now are the education professionals. We're all dealing with that. I think it overshadows the medicine right now because both of those are what we're dealing with on an hour-by-hour basis. So let me thank all of you for what you are doing. Steve, I'm going to share the screen now, and we'll try to make it work. There we are. That's satisfactory?
Yep.
That's much better.
Great. Well, I'm only going to talk about these two things. Just a word about the Russian vaccine and what we know about it so far. And I'm going to spend the rest of the time talking about masks and what we know, and try to clarify some of the things based on the questions that I have been getting. This is the only comment I'm going to make about the Russian vaccine because we know so little. We understand that there were 76 researchers who vaccinated themselves in May. One of them was President Putin's daughter, who is involved with research. It is described by them as safe, effective, and sustained. But again, this was just May through August. They are now doing the typical phase 3 studies of safety and efficacy. So those have not been completed yet in Russia. But their plan is to immunize or vaccinate healthcare workers starting this month and introduce it to the public in Russia this fall. The vaccine has been approved as a drug by Russia's Ministry of Health. The response from professionals around the world has been mixed. There have been some criticisms, there have been some applause, but everyone is hopeful that this product will work. This is not an ego situation. We all want to see an effective and safe vaccine. Now, I was going to put this slide at the end, but I'm going to show it twice. It is concise, it is the answer, it addresses so much, and it was published this month by the Association of Medical Colleges. 3 big points. Wear a well-fitted but comfortable face covering and minimize the gaps around the nose, the chin, and the cheeks. If cotton is being worn, at least 2 layers is recommended. That's not 2 different masks, but a mask made of 2 layers of cotton. Indoors, always. When around persons from another household or another bubble, always, regardless of the distance. The air current inside can be stagnant. The virus can live longer. So indoors, always, when around someone from another household, and outdoors, only when you're less than 6 feet apart, even if it's for a few minutes. So if you're passing someone on a sidewalk, you want to wear a mask. But more than 6 feet apart, it's not necessary. 3 simple rules. If we all follow these, we've got it made. Masking is our only effective force right now to control this virus. We don't have anything else, and yet it's very, very simple. Now, I will say that there are some regulations that are more strict that have been published by, or at least put out by the county health officers or state. We have to follow the rules of our own community, but this is what's coming down nationally, and it's very, very concise, very good. So I showed this slide before, but it caused me to go back and read more about it. All of these were pictures taken in the United States. This was the 1918 influenza epidemic that went on for 2 years, infected 500 million people. The number of deaths is unclear, but probably about 25 million. 500 million people were infected. We are now worldwide at about 23 million. This virus was seasonal, and the COVID is not. So there were times when the virus was at a lower level in the United States, then it would come back. Remember, influenza is seasonal, coronavirus is not. but it did go on for 2 years, resulting in about 50 million people that died. Now, the other important thing is that it's so analogous to what we're looking at right now. And I had to go back and look at this. There was not a national mask mandate, but rather masking was local. San Francisco insisted on masking, but Oakland did not. There were some states where the governors insisted on masking and some states where the governors said you don't need it. There were counties where masking was required. There were counties where it was not. So it's almost identical to the local rules that we are seeing going on right now. So why do we wear a mask? So I've divided these into two sides of the slide. On the left side is what we do in a hospital. There is a N95, and everybody has heard this word. A fitted N95 is a picture of what we're looking at there. Fitted means that when I put on this mask, I have to go into a room and use chemicals to be sure that nothing goes around the outside of that mask. It is fitted to me. And there's several products, and I will pick the product that fits the shape of my face the best. And this is what a provider wears when face-to-face treating an individual in the hospital or treating a person who is infected. This protects the wearer. This filters inhaled air. The surgeon's mask is below it, and the surgeon's mask is completely different, and it filters exhaled air. Now, it looks like a lot of masks that you see people wearing on the street, but it is not. This is specifically designed to filter exhaled air. You can see that it ties around the back. It doesn't have ear loops. So in order for it to tie around the back and not slip, it requires a surgeon to wear a surgeon's cap. This is 2 layers of paper with a polyester filter between it, all designed, and it has specific specifications to filter exhaled air so that what is in the nose and throat of a surgeon doesn't enter an open wound. Now, the CDC defines a big difference between mask and face covering. That's just not going to fly. We use the term mask colloquially, we use it in public, so we're just going to have to talk about all of this being masks. In the community, masks or face covering are defined to protect others in case one is unknowingly shedding coronavirus. And in contrast with the surgeon's mask over here that has specifications that must be met, these are variable. And they variably filter exhaled air. And that's where we're going to be. We're not going to get to a point where we're demanding specifications. We want people to be comfortable. Variable filtration is just fine. So I'm going to talk a lot about this today and what we know so far. Now, the term has come up repeatedly is what is the difference between an N95 and a KN95? And the N95 is on the left. This is fitted. This is what I've talked about before. It's designed for a caregiver to protect a patient. The KN95 is similar in its filtration ability, but it is not fitted. This is something that you can buy commercially. There will be air leaks around the outside, around the cheeks, around the chin, around the nose. So this doesn't work in a hospital. It has ear loops rather than ties, and it's loosely fit, and it's kind of comfortable. If you like it, it's fine, but it is no better than fitted cotton, and I'll show you a little bit about that in a moment. But I use these when I'm out in public because it's comfortable and people give them to me. But a KN95, although the filtration capacity is the same, it is not fitted and it's not acceptable in a hospital. And similarly, the difference between a surgeon's mask and the ones that you would buy commercially, they look the same. But the surgeon's mask has very specific criteria for filtration. The ones on the right are very good products. We want to see people wearing these, but they have no specifications whatsoever. And usually they arrive in a bundle, as you can see in that picture on the right, that there's no description of what they do, but they're fine. It's a good product. They are disposable. They're inexpensive now. These were the ones that were very hard to get in February and March. They're widely available. And I encourage you to use these if you like it, a KN95, or any of the other products. Now, speaking of the other face covering or masks that are in public, there was one study done at Duke that attempted to compare several products that could be commercially prepared. So going from the left, the fitted N95 that I would wear in an intensive care unit is the first one on the lower left. And the y-axis is the number of droplets that come through a mask. So obviously the ones in the hospital, the expensive ones, the ones that are designed with specific filtration capacities are the best. And you can see that almost no particles gets through a fitted N95. A fitted N95 protects me from a patient. It also protects a patient from me. Very expensive, very difficult to use because fitting is required. And then what they did at Duke is they just purchased a bunch of things across across the bandana and fleece. This shows the amount of droplets that are expressed. Let me go back up. This shows the number of droplets that are expressed if you don't wear a mask, and fleece is actually worse than a mask. And I know what fleece is, but I wanted to go back and look at it a little bit so I could discuss it. This is fleece. Fleece is a brushed cotton or a brushed polyester. But the important part is that it's brushed, and it's brushed so that it's soft and warm and comfortable, but brushing loosens up the fabric and almost makes it like a screen. So there is essentially no filtration of a fleece face covering. It's something we do not recommend and do not want to use. Now, in contrast, when the Duke study came out and said that bandanas were bad, there was a lot of pushback. And I've titled this slide, "All Bandanas Were Not Created Equal." The one on the left is the typical bandana. It is from India. It's a combination of silk and cotton. It's colorful, it's often paisley, and it is not recommended. But the ones on the right are also called bandanas, but they're made of double layered cotton, and they are very good. So we have to be cautious. What I think we see down here on the left-hand side, the typical bandanas that have been around for centuries, these are not recommended. They're just not that good. But anything that is double layer cotton and recommended, like a neck gaiter, as we see here or here, these are pretty good. So just because they are called a bandana does not mean they're bad. And a comment about face shields. Some have asked me, is a face shield a satisfactory substitute for a mask? And the answer is no. There's specific uses for a face shield. We cannot recommend them to replace a mask. In a hospital, it's common to wear a face shield and a mask because it really protects the caregiver, the provider, from splashes, from getting material into the eyes. Masks don't do that. Rarely, coronavirus is spread by acquiring it through the eyes, but it's uncommon. It's the nose and mouth that represent the source of infection. But if somebody's coughing or spitting, a mask can be helpful. So it's very good for first responders and selected situations, but not to replace a mask. And remember, if we look at the slide over here, we wear a face covering or a mask to protect those around us. There's absolutely no information that wearing a face shield protects others around us. So it is not to be used for that. It is used to protect the wearer in a very few selected situations. So what doesn't work? This is what you don't want to see. On the left side are valves with masks. After a lot of CDC discussion, we finally changed the CDC recommendation that does come out and say, do not wear a mask with a valve. what happens, as you can see this is KN95 fabric. So excellent filtration, inhaling, but the mask has no filter at all. So since we are wearing masks or face coverings in public to protect those around us, this completely negates the situation. The valves are exhaling, are open during exhalation and putting virus into the air. These are really made for industrial situations. And you can see what this person is doing. Wearing a mask to prevent the inhalation of particulate matter, of dust, of sawdust, of shavings, of metal, then you don't want a barrier to exhalation. So masks with valves should be avoided during this current epidemic and reserved for industrial use. And then on the right, I tried to show an analogy of what you see if you wear a mask below your nose. It's just like a diaper that's not worn correctly. It's not going to work. What we see here is an individual wearing a mask below the nose, and this is probably one of the more common errors that I see as I walk down the street. Remember, this virus is exhaled from the mouth and from the nose. A face covering or a mask of any kind needs to cover both the mouth and the nose. And here is the good new finding. This just came out at the end of last month, just a few weeks ago. A wonderful study that shows any face covering that we wear, any mask that we wear, also partially protects us. We have been saying what we do in science for the last 5 months, that a mask is an exhalation filter. A face covering is an exhalation filter, and we wear it to protect those around us, to show them that we care. Now we find that that same filter does partially protect us. Not completely, not as good as what I would wear in a hospital, not as good as what a care provider would wear, but it does partially protect us. In some elegant studies using these paper masks that can be purchased commercially, using double layer cotton that can be made or purchased, partially protects us. So remember what I said. Right now, we don't have a vaccine. We don't have a medication. Masking or face covering represents our best weapon against this virus. I get asked all the time, do I favor universal masking? Absolutely, I do. It's not a requirement, but I truly favor universal masking until we get a better weapon against this virus. So it partially protects the wearer and definitely protects the individuals around the wearer. So I told you I would show you this slide twice. It's simple, it's concise, it's what we need to do. Wear a well-fitted, comfortable face covering, minimize the gaps around the side if you can. And if it's cotton, 2 layers. It doesn't get any better than that in the community. This will stop the spread of this virus. Indoors, always, if you're around persons from another household, even if you're across the room from them, and outdoors, it's not necessary from the medical side unless you're closer than 6 feet. And I know that some counties, Alameda County and Contra Costa County may have different recommendations. I can't keep them all straight. I recommend that we do follow the guidelines of the public health officer in our county. But these are now the consensus guidelines. And if we follow these are simple. If we follow these, we will control this epidemic. We will stop new cases, or at least drop them by 80%. That's all it takes. We really, really need to do this. And so the last slide, many excellent studies show universal masking significantly lowers transmission. We all need to do it. Wear a mask, show others that you care. Wear a mask, show them that now you can say, I'm smart, I'm partially protecting myself. And Mr. Mayor, with that, I will stop, and we have time left, and I will let you decide what to do.
For Dr. Joseph, and you were explaining your chart about the materials for the masks and the types. Unfortunately, you did cut out for just a brief second on the chart. So there is a question related to that. I wanted to make sure that it was clear. It's from somebody who wears a neck gaiter at work, so the full neck covering, not a bandana, and reading about studies that the gaiters might make it worse because the mesh breaks up the particulate matter, and then the finer particulates get out and are suspended in air longer. So would that be mostly related to the style of mask, or is it the material? Because some of them are made of cloth, but then others are like a polycloth blend.
Thank you. It's not the neck gaiter or the style of the covering, but rather the material. We're finding out that the most reliable material is woven cotton. Tightly woven cotton is the best, and 2 layers. So it really doesn't make any difference if it's a mask with ear loops, if it's a neck gaiter. But really, we need to avoid polyester if possible. Definitely avoiding fleece. But there are many cotton neck gaiters out there that are just fantastic. There are neck gaiters out there that are fleece and should be avoided. So it's the fabric, not the style.
And Steve,
oh, yeah.
Steve, I'd say, and given the time, I was going to ask Dr. Joseph, since he was talking, there's also some studies being done and tests to give instantaneous results on whether or not somebody has COVID. Could you give us an update on what is the status of instantaneous tests?
Instantaneous tests are frequently called antigen tests. And it is not PCR that we've talked about so many, many times. The problem with an antigen test is that it's only useful in high prevalence circumstances. It's not good for what we're seeing right now with a very low number of people being positive. A negative antigen test has to be followed up with a PCR test. So if we tested 100 people in San Ramon, we might find 5 or 6 or 7 who are positive, but all of the other 95 or so would have to be followed with a PCR. So what we want right now, since testing will solve the problem, instant testing, we want a rapid test, a 5-minute test that will give us a reliable negative. We're not there. Supervisor Anderson mentioned the saliva test, and there are 2 now that have FDA authorization. One was developed at Rutgers, which I know very well. One was developed at Yale. They're both PCR tests, but they do have the time limitation of doing the PCR laboratory component. So they're not rapid tests, they're just convenient.
Great, thank you.
Dr. Joseph, there's a question regarding a comment that you made several broadcasts ago about sewage testing as a way for early detection of COVID-19. And the question specifically is, are you aware of any of this being conducted in Bay Area communities?
No, good question, but not in the Bay Area. The CDC, the Center for Disease Control and Prevention, has launched a campaign doing sewage testing at certain hot spots around the country, but the Bay Area is not included. I don't know if the State Department of Public Health will want to do this. Currently, it's United States Public Health Service that's doing it at scattered areas around the country. But it's taking off, and it's still very, very good. A great way to define a community that is at risk.
All right, and another question for Dr. Joseph. In March, CDC guidelines for hand sanitizers discouraged the use of sanitizers with benzalkonium chloride as an active ingredient instead of alcohol. Have there been any recent studies that BC can be effective against COVID?
Well, benzalkonium chloride is a quaternary ammonium, and it is effective, but it doesn't last very long, and it takes a lot more contact time than alcohol. The main reason that it was not recommended, it was being promoted as the sole active product, and it takes about 30 seconds of rubbing your hands with a quaternary ammonium to control the virus. There have been some products that come out that include that and other enzymes that are now being studied. So right now, the recommendation for a hand sanitizer is any of 2 alcohols or either of 2 alcohols. That's ethyl alcohol or isopropyl alcohol, with the same recommendation to avoid methanol or methyl alcohol.
And for Dr. Joseph, What are you hearing about treatment of infected patients? Are there any effective treatments that are being used widely today? And also, I know you spoke about blood plasma treatment earlier, and apparently the FDA is putting that on hold for some reason. I don't know if you have any comments about that.
Yes, on both. There are well over 80 clinical trials investigating drugs. None of those trials yet have come to fruition. So the treatment that we've discussed before is still the same. Since the seriousness of the disease, now let me say the first part. The first part is the mild disease, that is those individuals who are not hospitalized, there is no treatment at all. It is supportive care and self-isolation. For those who are hospitalized, who have underlying respiratory disease or in an intensive care unit, that's usually due to an overactive, uncontrolled immune system. And so the treatment for that is to back down the immune system, usually with immunomodulators, corticosteroids, various other drugs that are available to block the immune system. And then the one drug that has been approved is remdesivir, which is an antiviral. I did mention plasma. I still am a big proponent of that. I will say this, that there have been about 7 or 8 studies that show a definite beneficial effect. But for the FDA to approve something, it has to be a particular kind of a study. So all persons in my situation are optimistic, but it has not, and we're using it. This does not mean it can't be used. So it's being used in our community, in our local hospitals in Contra Costa County. It's very good, but it has to meet a certain level of testing before the FDA can put the stamp on it. But it is available, it is being used, and those studies are going. It's only on hold because it just hasn't quite met that level.